I decided today that going last is actually the worst place to go, and not because everyone falls asleep after lunch, but because all the sort of fun stuff was already told. So you've already, have seen lots of pictures of the skin, you've heard about the stage, and so usually when I give a talk like this, I come in, I do what they've already done. So now I'm just left with not a very short talk, talking about some of the therapies that are available. And as I've been talking to some of you today, and you've already gotten a picture that the management of cutaneous T-cell lymphoma is really a multidisciplinary thing, and that's why, Edith and I have a multidisciplinary clinic so we can see patients together. When I was at Duke before, Dr. Kelsey and I worked very closely together with our patients, so you really need patients, different fields working together. But happily, most patients do have early stage disease, and they spend their time in dermatology. And that's where they stay. Even if it progresses a little bit, they can get pills or whatever. Maybe they go to radiation for one spot or something. And so it's a minority of patients who have to go to the oncologist, which is a good thing. But the other good thing is that advances are being made. There are actually drugs that are FDA approved for cutaneous T-cell lymphoma, which is a pretty big deal for such a rare disease, one of which was just FDA approved in the last few weeks. So that's very exciting.
What's that name?
Oh, it will come. I think I put it last. I feel like my patients who are, like to read all the websites have been asking me about it for months, and then at the moment I mention it, they would all leave. So anyways, so I'm skipping all. It's basically, I'm just going to have a list of treatments is what we're going to be doing. But Dr. Kelsey already sort of talked about this. There are a lot of different cutaneous T-cell lymphomas, or different T-cell lymphomas in general. But really what we're all talking about today mostly is the mycosis fungoides and Sézary syndrome. And I'm not going to talk about the cutaneous B-cell lymphomas, which primarily are radiation treated, as Chris already said. So this is a diagram that I see very often, and it kind of talks a little bit about where do different therapies come into play through the course. So here we're having people who have limited stage disease, stage 1, so patches and plaques, and this is really when you're definitely talking about dermatology. You might have steroids or nitrosamine cream or bexarotene cream or the light therapy. And as people's disease gets more advanced, you start to maybe the oral bexarotene or the oral methotrexate. Maybe you need radiation, total skin, or that photopheresis that she was talking about, where you kind of pull the blood off and treat it and put it back in. And it tends to be when people get more advanced disease, or a disease that's gone through a lot of therapies and hasn't found something that's working well, and we start talking more about seeing an oncologist and doing chemotherapy. But really, many of these things are happening all at the same time when we get to advanced disease. So, treating mycosis fungoides and Sézary syndrome is, at the same time, the most frustrating part of my job and the most satisfying. It's most frustrating, which you guys probably know better than I do, because people come in and, unlike some other cancers where I say, oh, you have this, here's the treatment, we treat you, yay, see you later, and they go off their merry way. It's not quite as easy as that sounds, but it's very clear, here is the treatment. With mycosis fungoides, especially when you start getting into systemic therapies, there isn't a sort of, here is the perfect drug. This is the drug that's going to work for everyone. This is what we start with, and everyone's going to have a great response. And so it's much more, you know what, we're going to try this treatment, and let's see if it works. And not let's see if it works for a week, but let's see if it works for 2 or 3 months of waiting around to see is this going to work. And if it doesn't, let's try the next thing. So sometimes, and I talk to my patients a lot about that because I don't want them to feel as though we're experimenting on them. Because we're experimenting to see if this drug's going to work on them, but it's because we don't know. There's no way to predict what's going to work on which person. So that can be very frustrating, but when it's most satisfying is when you find the thing that works. And I'll tell you, then the patients come into your room, and then you're running out and pulling the nurse and assistant or the pharmacist they saw once or whoever to say, come look at the skin, and how well the patient's feeling, and it's just fabulous. So mycosis fungoides, it's a chronic illness, as we talked about. Once you have this, most people are getting treated for this their whole lives. And we do sort of systemic therapies and topical therapies, and interestingly, sometimes we reuse a treatment. So if we treat someone with something 10 years ago and it worked, and then we've gone through all these other things, we might say, let's try that again. You know, it worked really well, let's give it another try. And sometimes that can be effective. The other thing that I talk a lot about in my patients is complete remissions, which I think I write about another slide, but a complete remission is where we look and say, your skin is normal. There are no enlarged lymph nodes. Your blood tests are all normal. You are complete remission. We can't see any sign of the cancer around. That is really unlikely to happen with this disease. So when we're treating, our goal is not, I mean, it's wonderful if it does happen, but our goal is not, let's have no evidence of disease. Our goal is, do you feel better? Is your itching a little bit better? Are you taking Benadryl just to help you sleep at night rather than all day long mixing it up with any other anti-itch medicine that you can find? And so decisions about when do we change therapy, you have to help guide us in that, because a lot of it is, has this helped you? Is it still helping you? What's going on? Is it time to try something else? Or have we improved your quality of life enough that, we're in a good place? So, and then Edith already talked a little bit about sometimes we use antibiotics or other things just because it can be a risk of increased infection. So I love this quote by Dr. Zanzani. And it says, the aim of treatment of relapsed refractory cutaneous T-cell lymphoma is to safely induce prolonged remission without compromising the patient's immunity or adversely affecting their quality of life. And this is so important because you're going to be on treatment for years and years and years. If someone is just going to get treated for 4 months, I'm willing to give them 4 or 5 drugs at the same time and make them feel bad because it is an endpoint. But we need to get you treatments that are helpful and tolerable for the long term. So, when do we use systemic therapies? Occasionally in early stage disease, if someone is really refractory to other treatments, but usually these are patients that are not coming my way. There are some sort of subtypes of mycosis fungoides, certain pathological findings when we look it up at the microscope that make me think this is going to act a little bit more aggressively. These are patients that maybe we need to treat with therapy earlier. And then patients who have advanced stage disease, blood involvement, widespread disease are patients that often we're talking about systemic therapy. So what are the systemic therapies? So most of the therapy is not kind of the classic chemotherapy drugs, but there's a few other in addition to this, but these are probably the 2 chemotherapy drugs that I use most often if I'm going to use the chemotherapy approach. I wouldn't use them both at the same time, so again, just one patient at a time usually. So gemcitabine, this is given IV weekly, so it's, it's not terrible. You're not coming every day, but it's once a week for 3 weeks, usually with a week off. But sometimes if someone's not tolerant, they'll say, let's do 2 weeks in a row, or every other week. So there's some variability in how I do this. And because these chemotherapy drugs have been around a long time, nobody really did big studies. Let me see how patients with cutaneous T-cell lymphoma do on this. Our data here is sort of more anecdotal. Let me look back. I treated 20 patients with gemcitabine. Let me look back and see how they did. And so if you look at the reports, about 60–70% of patients who get gemcitabine will have a response. Most of them, most of them is not a complete response. So it's some improvement. To be qualified as having a response, it usually means you have to have had at least a 50% decrease in your disease. So it really is a significant improvement, not just one little spot on my arm got better. And most of the side effects I see with gemcitabine are more things that I'm checking on the labs. So my patients come in, they're feeling pretty well, and I might look at the labs and say, oh, your liver tests are a little bit abnormal, or your blood counts are a little bit low. We have to decrease the dose or hold the dose this week. It's not usually them coming in and saying, oh, I don't feel well, my stomach's hurting or anything like that. There can be some fatigue, but overall people tolerate this pretty well. I think I had one patient on it for about a year and just had an amazing result. A patient that Chris and I shared. She's gone through every therapy. She had a lot of time radiation as well. But, and then so sometimes I'll use liposomal doxorubicin. Again, this is a single agent drug. I probably use it less frequently than gemcitabine, but again, it's every other week for up to 6 months. This drug, the main toxicity that can happen is some toxicity to the heart, and so that's why it really is limited to a certain amount of time. You would check someone's heart function before you did it. Depending on which kind of report of patients, some reports say almost half of my patients responded. Others say 80% of my patients responded. So, and in one report, complete response is up to 42% of patients. So this can be a very effective drug. But I'd say that the thing that we're doing more frequently in cutaneous T-cell lymphoma is not kind of the classic chemotherapy that you use in lung cancer or other things. It's really these other drugs that have different mechanisms of action. And I should have put this up earlier, but this is, because you'll hear me talking about this overall response rate, I thought I would just explain what these things are. So you'll see this ORR, overall response rate, and that really means what percentage of the patients responded to this therapy. And as I said, a response generally is at least a 50% reduction in kind of their disease burden, whether it's in their skin or their lymph nodes or other places. It's a little bit different in cutaneous T-cell lymphoma, but that's the basic idea. A complete response rate is when somebody has just no evidence of disease no matter what test you do. I think this one, time to first response, it's phrased a few different ways on different slides, but this is basically how long do you have to be on the drug before most patients have a response to therapy, which speaks to us. You know, we say that often you're trying this for many months before we decide do they work or not. And then duration of response is for those patients who have a response, the patients who have a response, how long does it last? Another very important question. So these drugs are called histone deacetylase inhibitors. There are two of them that are actually FDA approved for cutaneous T-cell lymphoma. One's called verinostat, one is called romidepsin, and they have some similar side effects, but verinostat is given as a pill. And I see that people have perhaps a little bit more GI toxicity with this, which isn't too surprising. You know, with the pill, maybe a little bit more nausea, a little bit more diarrhea with it. And the romidepsin, which is given IV, you know, once a week with a few weeks off here and there, kind of like a lot of these drugs, is pretty well tolerated. With that one, occasionally it can cause some changes in the EKG, which is kind of a thing looking at kind of how is the heart beating. In the studies, they didn't really find that there was any clinical effect from that, but sometimes we'll follow the EKGs and make sure the magnesium and potassium are good while you're on it. So with this, again, this is a number that will come up pretty frequently, which is that response rates, overall response rates, of about a third of patients. The complete response rate pretty low, so 1 to 6% in these studies. And the median time, the average time to the first response, 2 or 3 months. So you've got to try these drugs for a while. But for the patients who have a response, the duration of response, particularly in the data reported with romidepsin, although part of this is for study reasons, were over a year. So patients who have a response can have a really long remission phase. So pralatrexate, this is a little bit like methotrexate. So you remember Dr. Bowers was talking about that there's pills, methotrexate, that are taken. Occasionally I use methotrexate at very high doses in cutaneous T-cell lymphoma, but not that often. I'm more likely, if I'm going to go that route, to give pralatrexate, a slightly different agent that may be a little bit more able to get to the cancer cells than methotrexate. It is FDA approved for a different kind of T-cell lymphoma, sort of a systemic, more lymph node T-cell lymphoma, but there are some reports of it being helpful, and I have seen some patients for whom this has been very helpful in management of their cutaneous T-cell lymphoma. So in this, there actually was a study in which, so a little bit better data than we had with the jump site and the Doxil, and 54 patients. And they had a median of 4 prior systemic therapies, so basically an average of 4 therapies. So half the patients had gotten more than 4 prior different pills, or they got a verinostat, or they got methotrexate, or whatever, so pretty heavily pretreated patients. And what they found was an overall response rate of 40%, so similar numbers, what we keep saying, mostly partial responses. Again, median time, average time to your best response, about 2 months. And here, I find that patients can tolerate this quite well, as long as their doctor is on top of this, sores in the mouth. So if someone's getting a sore in the mouth and the doctor says, oh, well, here, take your drug anyways, by the next time you see them, they're going to be in big trouble. But if the doctor says, you have a sore in your mouth, we're decreasing the dose, we're holding it this week, or doing some other supportive care things, then people can do really well. So that is very good. Most people will give vitamin B12 and folic acid supplements to try and prevent that. Fatigue is pretty mild. Mild nausea are also reported in the studies, but that's more what comes up in the studies. My patients don't really complain about either of those very much to me. So most of the other things that we use to treat cutaneous T-cell lymphoma, and this is sort of the buzzword of oncology right now. It's another thing, I have patients come into my office and say, hey, can I have some immunotherapy for this? And I say, all right, what do you mean for that? So what that means is immuno is basically your immune system. So your immune system's job is to fight off a virus, fight off a bacteria. It's supposed to recognize that there's something foreign in the body. And it's supposed to recognize that there's a cancer cell in the body. They're not normal cells. And in fact, probably everyone has a cancer cell in the body here and there that their immune system gets rid of. But when cancer happens, it's slipped through all of these processes. And we have learned more and more about how do we help the body's immune system recognize these cancers more? How do we kind of get it revved up? And so think about it, here's a cancer cell, and on the outside of every cancer cell, every cell in the body, there's these different markers or road signs, I call them. So if you make this thing called a monoclonal antibody, which goes in and targets, so this one's going to target the triangle. So it goes there, because there's triangles on cutaneous T-cell lymphoma, for example. It goes there, and then it sends out these signals to bring in the immune system saying, hey, come right here. So these are really great, especially if the triangles are only on the cancer cells and not anywhere else on your body, because then it can be very targeted. So alemtuzumab is a drug that can be very effective, and this is one of the first drugs of this sort that we use in cutaneous T-cell lymphoma. It's not FDA approved for this indication, but one of the signposts on cutaneous T-cell lymphoma, as well as some normal cells, is CD52. And so this drug goes in, it binds to CD52, and can help target the immune system to that area. And so this, again, most of this data is kind of people saying, hey, I treated 20 patients with this or whatever, but the response rates range everywhere from 38% to studies saying 100% of my patients had a response to this. And I'd say most of the reports average about 80%. So really very high response rates. Complete response rates are even a little bit higher here. I'd say the place that I think this is the most effective and where I use it are patients with Sézary. So if someone just has, with blood involvement. So if someone just has lots of patches and plaques around, this is probably not what I would go for, because I don't think it's quite as effective in that situation. There are, the median duration of response, depending on what your report you look at, is 6 to 12 months, but there are definitely some long-term responders. So I found this to be extremely well tolerated. There's two issues with it. One is look at the schedule. So how we're talking about the coming in for light therapy or whatever. Here we are again, Monday, Wednesday, Friday for up to 3 months. And it's given IV or as a shot. It's probably a little bit easier to get this locally than light therapy, for example, because if there's local oncologists, they can't get this drug to do it. But that's a big issue. The other issue is that normal parts of the infection fighting system have CD52 on them, so those can also get suppressed. And so when patients tolerate this drug well, they do great, but there are certainly increased infections that are seen with this, so I'll have patients on a lot of medications to suppress infections and monitor them quite closely. So brentuximab vedotin is sort of the next generation of this idea. In this case, it's targeting something called CD30, so the signpost on the cancer cell was CD30. And it goes and binds, and it can bring the immune system to that area. But brentuximab vedotin also has chemotherapy attached right to it. So it binds to the cell, and then it brings inside, and it brings the chemotherapy right inside. So it's sort of this very targeted chemotherapy. And this can be very effective. The problem is that not every cutaneous T-cell lymphoma has CD30 on it. So for some patients, if they have CD30, this can be an excellent option. But if your cutaneous T-cell lymphoma does not have that signpost on it, then this is not something that would be that helpful to you. But here, we're talking about how, first there were just kind of case reports. I just treated 10 patients, this is what happened. And then there were small trials of 54 patients. Now we have our first randomized study. So what does that mean? That they took 130 patients. That's a big trial for such a rare disease, 130 patients. And they kind of, now it's a computer, but basically pick out of a hat, hey, you get the brentuximab vedotin and you get our alternative treatment. And so half of the patients were randomly assigned to get brentuximab vedotin, the drug I was just talking about, and half were assigned to physician's choice of either the oral methotrexate or the bexarotene pills that Dr. Bowers was talking about earlier. So this is patients, they all have to have CD30 expressing lymphomas. So some of them were including some other kind of cutaneous lymphomas, but about 3/4 of them were mycosis lymphoides, so most of these patients had this. And I thought it was really interesting. So primary endpoint means when they do the study, how they determine success. And I really like this because you don't see this often. They made this thing called ORR4, so overall response rate lasting at least 4 months. They said, you know, if you have a response that lasts for 1 month, is that really meaningful? Maybe not. Let's really look at who has are we getting patients into responses that are more durable? And so what they saw was just responses in general, 67% of patients with rituximab vedotin versus 20% in comparator arm. And most of those did last more than 4 months. So this overall response rate of 4, and a bit over half of patients with rituximab, 12% of patients with methotrexate or mixerotine. And complete response rates, not great, but 16%, actually that's pretty good compared to most of the studies. We had 16% of patients who were in a complete response with lymph node, blood, and skin involvement. But what's interesting is look at the median duration of response, which is great. You know, it's a bit over a year for both of these. And what it says is that if you find the treatment that works for you, then you can have durable responses. So see, not nearly as many people respond to methotrexate or mixerotine, but if they did, then that could really do well for them for a long time. And that's why we say, oh no, who's going to respond to what? You know, we try, and when you find something that works, stick with that until it doesn't. The big side effect of this rituximab vedotin is neuropathy, so numbness and tingling in the fingers and toes. And so this drug in these clinical trials was given up to a year. In clinical practice, sometimes we give it even longer. But the main reason people would stop this is either it's not working anymore or because they get this neuropathy. Most patients, it will improve. It does not always completely improve afterwards, so this is something that needs to be monitored quite closely. And if it's going to happen, it's not going to be after one treatment. Usually it's after you've been getting it for months. So mogamulizumab, this is the drug that was just approved in the last couple of weeks. And it's been in use in Japan for a few years now, but just got it approved here in the United States. So I know that in UNC, and I'm sure at Duke or Charlotte or Wake Forest or wherever, that everyone's busy getting this on their formulary, so hopefully the next month or two it will actually be available for patients to get. So this is a monoclonal antibody. In this case, it's targeting something called chemokine receptor CCR4. You do not need to remember these things. CCR4 is found on MF on the mycosis fungoides cells. It's also found on part of the immune system. And so it works two ways, one by attacking the actual cancer and bringing the immune system to it, and also by helping to make the immune fighting cells a little bit more effective. So, you know, I was excited about 54 patients, then I was excited about 130 patients. Now we have a randomized trial of 372 patients, and this just speaks how people are getting more invested in doing research in this disease type, and that they're really making good studies. So in this case, patients were randomized mogamulizumab. It's given once a week for the first month, and then every other week indefinitely, you know, as long as you're tolerated and have no response. Versus brinistat, which is one of those, the pill histone deacetylase inhibitor that I mentioned earlier on. So patients randomly in each group. Median age about 64 years, median of 3, average of 3 prior therapies, so patients were relatively heavily pretreated. They excluded 2 groups. Patients with large cell transformation, which sometimes mycosis fungoides can change to a more aggressive lymphoma, which we call large cell transformation, and that's treated in a whole different sort of way. And they also excluded patients with active autoimmune disease. So this is the one downside of us doing all these medicines to rev up your immune system to get it to target better, because it's going to target the cancer better, we hope, but it also can target normal cells in the body if the immune system is just sort of revved up. So if somebody has an autoimmune disease in the beginning, which means that your own immune system is targeting normal parts of your body, you don't want to rev up their immune system more, because they could just get more ill. So patients who have some diseases are not eligible for these drugs. So what they found here, so just kind of good response overall, you can see is much higher in the mogamulizumab than the brinistat. They broke it down by different sort of, let me just look at patients just with the skin involvement, how they do, or just, you know, their lymph node involvement. You can see within all the subsets, skin involvement, lymph node involvement, as well as blood response, is much better in the mogamulizumab arm versus the brinistat arm. And the duration of response looks pretty good. So within the skin group, median duration of response in people's skin disease, going out to 2 years, lymph nodes being shrunk over a year, and blood improvement over 2 years. So this is, for those patients who have a response, it really can be quite durable with this drug. Median time, the average time to response is about 3 months, even longer than brinistat. So I put this up here because, partly for myself and also so you guys can see, because this is a new drug. So whoever treats you with, if you guys get this drug, it's very possible that you're going to be the first patient your doctor has treated with this drug because it's so new. And so it's important to really look through and say, okay, what are the side effects and what happened? And so this is really interesting. So rash, well, it's kind of challenging to comment on rash, right? When you have somebody who has a rash, and then we treat them, and now they have a rash, which you were talking about a little bit with nitrogen mustard earlier. But so about a quarter of patients had rash. Everyone had rash, presumably, but rash that worsened during this, and it was sometimes it was even months after they were on the treatment. And 3.6% of patients with very severe rash, probably prohibiting continued drug. These rashes should be biopsied because you want to know, is it the disease progressing, in which case this treatment's not working for you anymore, or is it just a rash from the drug? Because sometimes you can have a flare-up just because the immune system is going in there, doing this thing, trying to kill the cancer cells, and so everything's just sort of inflamed and irritated in that area. And if that's what's going on, maybe you want to keep going and sort of push through that. The other thing that can happen is an infusion reaction while receiving the drug. So you get this drug, and it goes in and helps stimulate the immune system. And when the immune system gets stimulated, it can cause all sorts of messengers to go in the body. It can cause fevers, or people's blood pressure to get low, or their heart rate to go really fast. And this is typically going to happen while you're at the doctor's getting it, not sort of you call the next day because this has come up. And it occurred in about a third of patients. It was severe in almost 10% of patients. But usually it's really just with the first cycle. So even if you had a severe reaction the first time, you might say, well, we're still going to do it the next time. We're just going to monitor you that time as well. And then again, you can have some autoimmune things where the whole immune system gets revved up and it attacks normal parts of the body as well. So this, I put this up here because checkpoint inhibitors is another form of how do we help the immune system to work better. And there's not very much data for this in cutaneous T-cell lymphoma yet, but there's several of these drugs that are FDA approved for other cancers, and people are looking at it in cutaneous T-cell lymphoma as well. So this is really just, this is getting back to the sort of, 24 patients, sort of these small studies, early studies. But another area where, again, 24 patients, relapsed refractory cutaneous T-cell lymphoma, heavily pretreated, so 4 more prior therapies, overall response rates of 38%. But 6 of the 9 responders, so this 38%, 6 of them had a 90% decrease in their skin. So they weren't a complete responder, but 90% decrease is pretty good. So, and 8 of the 9 had continued ongoing response. So those patients, again, could get a response that could be very effective. I'd say any oncologist or dermatologist will say, if there's a clinical trial, you should consider that if it's appropriate for you, and it isn't always. So we have a clinical trial going on at UNC that I thought I would just put up here, and you don't really need to follow that. But basically, it's this thing called chimeric antigen receptor T cells, or CAR T cells. And some of you may have heard about this in the news because there are drugs now approved for some B-cell lymphomas and some leukemia that have been very exciting. So this is sort of complicated. One of my colleagues, Natalie, sort of made a little bit of an easier slide. So this is the T cell. That's your immune fighting cell. So it's not the cancer cell, it's your immune system fighting cell that we want to get out there to fight the cancer. And normally it's just there, it's not particularly targeted, it's going around. So what happens in CAR T cells, and I'll show you another diagram that goes through a little bit, is we actually take your own T cell, we use it, we draw it out with blood, and we send it off to the lab, and we modify it by taking these very specific targets, so CD30, so for example, if you have CD30 is the signpost on your cell, that's what we want to target, and putting it on your immune cell, and making it so it is ready to go. It is ready to look for CD30 and look for any cell that is expressing that. So we do that in the lab, and then we squirt it back into your IV, so that now we're putting your immune system back, and they're all targeted and ready to go. And so in this case, the newest study that was just opened is targeting CD30, which remember I talked about is on some cutaneous T-cell lymphomas, as well as CCR4, which I don't know if you remember, which is the mogamulizumab target. So it's actually combining both of those, hoping that we'll be even better at targeting cutaneous T-cell lymphoma as well as some other things. So this is much more complicated. This is the kind of thing you don't go into your doctor's office and say, oh, tomorrow we're going to start treatment, because they have to collect the cells from you, they send it off to the lab, it's there for a couple of months getting modified so they can express these, targeting agents. And then they test it, make sure all looks good, and then they infuse it back into. So this is a much longer kind of process. So hopefully, well, I'm writing another clinical trial using just other drugs, but that's far down the road before it'll be open. So this just kind of summarizes again kind of the things we talked about. Some chemotherapy. This is in no particular order, by the way, at all. Gemcitabine, doxorubicin, sort of more chemotherapy. These histone deacetylase inhibitors. Metallic mogamulizumab that was just FDA approved. Alemtuzumab, which is great for some patients with Sézary syndrome. Rituximab vedotin, which can be great if your cells express CD30. And now we actually have a couple agents that are specifically approved for this indication, which is really exciting. So basically, the take-home message is that this is an indolent chronic disease for most patients, and you're going to be getting treated long term. So we need to always balance what are the toxicities with what is the efficacy and the benefit of being on a particular therapy. And the goal really is to improve and maintain quality of life. And usually that's with the help of a dermatologist, oncologist, and a radiation oncologist. So that's it.